Alright folks, we're going to get started. So today we're pleased to have a visiting speaker, Tony Martinez, who we brought from upstate to downstate here. Tony comes from the University of Buffalo, and I want to do a special thanks to Natalia and Derek from AbbVie to help coordinate things and introduce us. So Dr. Martinez has a unique path all over the country, starting with residency at Boston University. Then he did his addiction fellowship here at Weill Cornell. And since then, he's really been in the front line of treating hepatitis C and has a lot of interesting stories and experiences to share with us. Faculty member at UC San Diego and is now at the University of Buffalo as the medical director of hepatology. So thanks, Tony, for coming.
Thank you very much. Thank you all for bringing me down. I appreciate it. Thanks to Doug and Scott. Thanks, Natalia. I don't know, just before I start, real quick, I don't know if anybody in the room knew a guy named Russ Perry. He's a friend of mine. He died about 2 months ago, and Russ was a absolute lion in the world of Hep C. He wasn't a guy who published a lot or got a lot of attention in clinical trials or stuff, but he was just a patient's doctor. And he's a guy I really looked up to. He did a lot of this work up in the South Bronx, and you know they're kind of feeling his loss. So if you knew him, you're lucky. He's a good guy. So in his honor, off we go. There's all my disclosures. I hate the learning objectives. I don't like telling you what you're supposed to learn. It's up to you. You figure it out on your own. Maybe you already know those 3 things. So there's still about 2.5 million people in the U.S. that are living with Hep C, right? Most of whom have some history of injection drug use. It's the #1 risk factor for Hep C acquisition. It always has, man. It always will be. And we've seen the rates start to triple since a certain point, right around 2000, and it's kind of hard to see up there, but around 2010, things start to take off. And it correlates with this opiate epidemic, okay? We're going to talk about injection drug use in general. I don't want you to just think it's opiates, and I'll explain more in a bit. Most of these new cases, though, are in patients who are under the age of 30. So we talk a lot about the baby boomers. In my clinic, we haven't seen a baby boomer. It's been quite a while. So the rates are kind of skyrocketing here. We estimate that there's somewhere around maybe 35 or 40,000 new cases annually, but I suspect that we're underestimating it, in part because these patients are hard to capture to screen. So I think that the rates are probably higher than that. There's 30 states that have reported increases over 200% in a 4-year period. So this thing is, it's not going anywhere. So Hep C and injection drug use are traveling partners. It only makes sense that they're kind of married to each other. If you look at IDU-related admits, they're up 622% in people 18 to 29. Hep C incidence is up 250% in women, particularly women of childbearing age. And then if you look at Hep C incidence in people 18 to 29, it's up 400%. So this all kind of correlates, right? I think it all makes sense. Injection drug use, I've said, is the #1 risk factor. Why? Hep C survives on the surfaces when people use not just needles, but cookers, spoons, cottons. I don't know how familiar you all are with banging dope, but looking at you, probably not. No offense. Just doesn't look like. Yeah. Younger people especially are more adept at transmitting the virus, and there's some reasons for that. They're more social than older folks who are still injecting. That's one, so they have a bigger use network. 2, they don't really know the rules of the game yet. They haven't been in detox, rehab, they haven't had a lot of harm reduction, so they don't know that they can't do certain things. So it's not just needles too. Anybody who's living with someone with Hep C, we always counsel on razors, toothbrushes, right? I mean, you guys probably see this in your clinic. It blows my mind when you tell them not to use the same toothbrush. They're like, what do you mean? I don't care if you have Hep C or not, it's gross. Just don't do it. It was on Curb Your Enthusiasm this week, actually, sharing toothbrushes. So the opiate thing, it's a huge problem. This is data patients age 12 and older. There's about 12 million people that are abusing some opiate. The problem is they bleed into this orange category where they start to escalate to heroin use. Then they get into the red category where they're just using heroin. The problem that we're seeing now is that this cascade has started to shift. It's coming up in a minute. Where they're skipping the whole oral-based opiates and they're going right to using heroin and fentanyl. And most of the heroin out there now is fentanyl. It's rare that we see pure heroin anymore, which is a huge problem. So this is a thing that touches everybody. Heroin use is increased across every single demographic, up 50% in men, 100% in women, people 18 to 25 up 100%. Look at the socioeconomic groups, whether you're rich, poor, somewhere in the middle, it doesn't matter. Heroin doesn't care. This thing has touched everybody. It doesn't care what insurance you have, but these rates have gone through the roof. So this data is interesting. This is from the Department of Health and Human Services when they do all their assessments annually of drug use. And if you look at heroin, past year 2017, 2018, it looks like it's gone down. So does methamphetamine. Looks like it's gone down. So that might reassure you. Problem is, when they ask these questions in these survey, they say, do you use heroin? You say, no, because I'm using fentanyl. But nobody asks that. They say, you using methamphetamine? No. Okay, no. Rates went down. They're actually doing is using goofballs, which is methamphetamine plus heroin combined. So the questions don't always get asked the right way. So these numbers, you have to take this with a grain of salt. They're actually going up. This is the cascade that I was telling you about. They start with the prescription stuff, escalate to heroin. Anybody know how much right now South Bronx is an OxyContin? Any ideas?
How many people?
No, how much does it cost for a pill?
On the street or in the pharmacy?
In the street. They don't go to get their drugs in the pharmacy. $80 a pill? It's $1 a milligram. So a 20 milligram oxy, right? $20. Anybody get high on 20 milligrams of oxy? My mom, maybe. I don't know. Nobody. Right? These guys spend $400, $500, $600 a day. A bundle of heroin is 10 bags, and that's $70. And now it's almost 100% fentanyl. That'll keep you higher, longer, and widely available. It's more economical. If you give me 10 minutes, I'll find you heroin before I'll find you a pill. So, like I said, it's not just opiates, it's also methamphetamine. So it depends where you go in the country. This is huge. If you're in Appalachia, it's everywhere. And the problem is that there's no MAT, there's no medically assisted therapy for it. So in my clinic, we've gone off the reservation. Nobody's like a lawyer in here, right? It's not being recorded or nothing. We've gone a little off the resi in my clinic, and we've started to use Adderall, is medically assisted therapy. And what we found is that it works. They lay down the methamphetamine. It's obviously not indicated for that, but there's no good solution for meth. They use it together with heroin. That's the goofball. And a lot of patients, what you'll see is they're on MAT for the opiates, so they're on methadone or Suboxone, but they still tox positive for amphetamines because they're still injecting. So that can become a problem, especially if you're treating Hep C. You think they're doing well, they're on MAT, they're not using opiates, but they're actually still injecting.
Methamphetamine is a big problem here in the city. And people on
MSM, in the PrEP community.
Incident Hep C cases. Mostly in that group.
Yeah, we were working with a group in Dallas, and it was the same thing. Their PrEP program, the STI rates went up 600%, and they had a cluster of Hep C, and they were trying to figure out what the problem was. And it was methamphetamine, but it was in this underground sex club. And you had to talk to this guy called the Dungeon Master. Like, you can't make this up. It's real. And so we met the Dungeon Master, and he invited us to come in, and we came in with the rapid test kits. And basically, you're like, we line everybody up, and okay, tonight you got to come with us. But there was a cluster of it, and it turned out that 3 people were using methamphetamine, and everybody's on PrEP. Nobody was protected, and you saw it.
The good news, only 33 new cases of HIV last year in New York City.
Because they're all on PrEP, right?
On PrEP.
Yeah. Crazy.
But
the STI rate's going up. Totally out of control, right?
Even enteric pathogens are back.
Yeah.
Cryptosporidiosis, antibiotics.
And that's just history repeating itself, right? Because remember in the old days, it was like so when chlamydia and gonorrhea, Hep C was right behind it. Right. It's scary.
For those who don't know, Doug was really one of the pioneers, one of the very first people to describe HIV manifestations in the GI tract. Right place, right time.
Yeah, but yes.
Right.
Maybe.
Not that you were in the bathhouse, Doug.
Well, it's like everybody had diarrhea.
Yeah, that's right.
In the early days.
Didn't know why. Yeah. So what we've seen with the average person who has Hep C, who is using drugs, in the old days, you tended to be middle-aged, male, African-American, and urban-based. The demographics completely shifted, and you've probably seen this. Well, some of you seem younger. You might not have. This might not be new to you, but the group that we see that have been doing this a while, now they're younger, they're whiter, they're more female, and a lot of times they're more suburban-based because of the opiate problem. So this was data from Massachusetts, and in New York, we see the exact same trend. And it's not unique to Mass or New York. This is everywhere across the country, border to border. That demographic of who has Hep C has started to shift. So we talked a little bit about young people and their use patterns. So every time you bring someone new into the use network, the incidence rate goes up with Hep C from 5.8 to 6.9 per 100 person years. It averages out to like 20 newly infected people every time they bring in somebody new. So we have this concept of treatment is prevention. So these active drug users, we especially want to engage in treatment if we're going to eliminate it because they're the ones who spread. Makes sense, right? If you go from increasing your frequency of injecting the less than daily to daily, incidence rate goes up 67% to acquire Hep C. So, you know, this is why we need to engage this population. 11 states, young injection drug users and young adults with Hep C have exceeded the baby boomers. Another 11 states, it's even. And then there's 4 states here that are completely full of crap. Michigan, Connecticut, Wisconsin, Colorado. A lot of those states still have restrictions as to who can be treated for Hep C. So the restrictions relate to sobriety. You have to be abstinent for 6 months before you can be treated. Fibrosis scores on liver fibrosis, and prescriber type. Have to be a specialist. Now, if you have restrictions on who you can treat, you're probably not going to do what? Look for it. So you're not going to screen. So I can tell you in Michigan, in the Upper Peninsula of Michigan right now, they have a huge, huge fentanyl problem. They currently have the highest overdose rates in the country in Michigan. Their rates of Hep C have gone through the roof. So I don't believe some of this data when they say that there's still a baby boomer problem because they're not checking the right people. So this epidemic now used to be the curve was the boomers, right? And then it became bimodal, the boomers and PWID. And now it's quasi-modal. You have the boomers, PWID, adolescent PWID, because they're starting as young as age 12. And then you have this kind of ghost cohort of children born to Hep C positive moms. So this is a population that we're starting to see more and more of. And Doug and I were talking a little bit about this today. So if you look at the rates in women of childbearing age, somewhere right around 2013, the rates of Hep C started to, in younger women, exceeded that of older women, right? 3.4-fold increase in acute cases. Show you some data from Kentucky. So if you look at this slide, the solid lines are the rest of the U.S., okay? U.S. children in green, U.S. women in blue. Look at Kentucky, the rates of Hep C, how quickly they've gone up. 89% from 1.8 to 3.4 per 1,000 live births. So this is a huge problem in women of childbearing age. Highest rates, West Virginia, almost 23 per 1,000 live births. The risk that you're born to a Hep C positive mom in the U.S. is 1 in 308. If you're in Kentucky, it's 1 in 67. That's nuts. That's nuts. How come? Well, down in Appalachia, in a 5-year period, almost 1 billion dosages of OxyContin and hydrocodone flooded into the area. 5 years. One town, Williamson, West Virginia, population 2,900, received almost 21 million dosages of hydrocodone. It's 717 pills per person. Guess what happens when you send this much opiate to a place? Everybody gets strung out. Then they closed all the syringe exchange programs, right? They limited access to getting the pills. But guess what? Everybody's still an addict, right? As a result, you see why these rates have started to go up. So this is there's multiple syndemics that are related to the opiate problem. The opiates being number 1, 2, acute Hep C, which we're talking about. Acute Hep B, rates have gone through the roof. West Virginia currently has the highest rate. Vertical transmission, we'll talk more about that in a minute. and West Virginia with the highest rate of neonatal opiate withdrawal syndrome. Another thing we've seen is that children born to Hep C positive females, 50% of them end up in foster care. So that becomes important because if you're seeing these kids, it can be viewed as sort of an independent risk factor, right? If you're in the foster care system, you should screen those children. So we look at vertical transmission in West Virginia in a 2-year period. You can see opiate abuse, the red line going up through the roof. You see the purple line right behind it, Hep C, comes right along with it. Look at the number of infants born with Hep C steadily increasing, and this is only going to get worse. When we look at the rest of the country,
21st century laser.
wow, look at that. That's phenomenal. I hadn't seen one of these in a while. This is the first colonoscopies. You saved it and petrified it. So I feel this is kind of cool. When we look at the rates of Hep C, I don't even know what to do with it at this point. Usually like
You have a laser pointer.
I think I do have that. When we look at the rates of Hep C in the rest of the country, in the U.S. across the board, we look in these 2-year batches, and you can see how the rates have doubled. And all of this just it correlates. It's one more thing that correlates with the opiate problem. So from the NHANES data, we estimated that there was somewhere around 130,000 kids that were living with Hep C. Okay, and that's old, 2003 to 2010. We know there's about 1,700 children born per year that we're seeing newly infected in the States. So these rates have gone up, 22% increase in women of childbearing age, 14% increase among infants. So this is a sort of new emerging cohort. We treat all of my patients are active drug users. What we started to do was screen the women's children. We started a screening program after one of our patients brought her child to us. So this kid is 5 years old. She brought him into the clinic and said she took him to the pediatrician, and the pediatrician said, he's probably fine, right? You know, no, you don't have to worry about it. I'm sure when he was born, they checked him. Now, the risk of vertical transmission is about 5%, close to 6%. If you have HIV on top of it, it goes up to about 11%. It's from this meta-analysis. So the risk that her kid was actually infected is pretty significant. So we checked him, and he turned out to be positive. So this is only a couple months back. She took him to the pediatric GI physician about a half hour away from Buffalo, and the guy said, there's no treatment for kids. Your kid's got to go into a clinical trial. And she asked me, is that right? And I said, that's insane. So as a result, I wrote the script. I was ready to treat the kid. We worked him up, and the hospital spazzed out, and they said, are you board certified in children? And I said, no. So they said, this clinical space is also not cleared to see kids. And when I took our space over, I'll show you a picture in a minute, there used to be like one of those vinyl Lion Kings that was stuck to the wall. It was like Simba, right? And I was like we have a vinyl Lion King. Like we must be fine to see kids, you know? Turns out we were not. So we now have a partnership with Family Medicine where we work collaboratively with them. We screen the kids then get treated. Our kid just started treatment last week. And then Doug and I were talking today, and hopefully we're going to have a little agreement working out with you guys. So part of why this is such a problem is the way the system works in the U.S. Mom gets diagnosed, maybe. Screening of pregnant women is not universal. It depends where you're at. We still see a lot of people who don't get screened. A lot of times they don't want to acknowledge risk factors because they're afraid of stigma, right? They go to the doc, they see the OB, they don't want to admit, I might have Hep C because I'm still shooting coke because now my kid's born. You're going to call social services. You're going to take the kid away. So there's failure to relay the information once the kid is born as well. Gets delivered, handed off to pediatrician. OB knows mom has Hep C, never tells the pediatrician. And we know with kids, when their immunity, it kicks over. You have to check them at 6 months, a year. We've seen rates, kids become positive even 18 months out. So they have to continue to be followed, right? So a lot of times these kids aren't getting tested. There's a long delay, change providers, go into the system, they're in foster care. Pediatricians don't know much about Hep C.
Well, even if I ask the mothers to have their kids tested, the pediatricians refuse.
They won't do it.
They won't do it.
Right?
I don't know what it is. They're allergic to it. They
I think
Can't get a PCR test.
Yeah, in part, I think it's because they're afraid they have to deal with it. You know, if we test for it and it's positive, now I got to figure out what to do with the kid. I don't want to do it. So there's still, this is sort of the next frontier of this stuff. So coming back to PWIDs, this was at ASLD this year. This kind of sums up the situation among this population nicely. So when you look at people who inject drugs, if they've ever been tested for, they've had an antibody test, a lot of them have been screened. The cascade starts to drop off, though, if they've ever had confirmatory testing. But if they're positive, do they initiate care? And you see, it just, every step of the way, similar to the general population, it declines. So young patients, young PWIDs, less than 10% have been engaged in the treatment. And historically, this has been unchanged. NATAP just produced a document that came out, I think, yesterday. 80% of people in methadone clinics have not yet been treated for Hep C. Doesn't make sense, right? Why do you rob banks? That's where the money is, right? So you know where the patients are at. They're all in places like that. So how come this population? Yeah.
The treatment, presumably most of those are cures, or what's the compliance like once you get them on treatment?
What do the cure rates look like, you mean?
Meaning, are they followed? Does that mean starting treatment, or that means cure?
No, this means initiating.
Yeah,
just initiating
so
treatment. Yeah, not even cured. Yeah, yeah. Because the cure rates, if you follow it even further down, it's like 4%. It just declines. So, despite this population being disproportionately affected by Hep C, they've not been engaged in care. How come? So the lazy thinking is that, well, they're just not interested. They don't want to do it. They're not motivated. They're too busy drinking, drugging, getting high, right? Not really accurate. We've surveyed this population pretty extensively, and what we found is 95% want to be evaluated and treated for Hep C. Number one reason why they haven't, they don't know how to go about it. So the barriers exist in three big buckets. Start with the patients themselves. I don't have any symptoms, I must be fine. I don't even know it's curable. I'm afraid of the shot. Saw my cousin go through it, my mom, my dad, my sister, brother, the hair fell out, they got crazy, started acting wackadoodle. I'm not taking that interferon stuff. You have interferon PTSD, right? I can't be treated because I'm still drinking and drugging. I got to get clean and sober for 6 months. So there's all these misconceptions in the street. Now the next set of barriers is systemic, right? You guys have a huge system, right? My own nurse called me today, and it took me 45 minutes to get through to her when I returned the call. I run the clinic, right? The system's hard to navigate. So if you're in a methadone clinic in the South Bronx and you get a referral to come down here and be seen on 98, for some of these patients, that's like telling them become an astronaut and fly to the moon. It's impossible. They can't do it. Take 3 buses, they won't do it. When I was at Cornell, we used to have them come across the street, just cross York. They wouldn't do it. Too hard, you know? So the system's tricky to navigate. There's concerns about stigma. They don't want to go to some place because they are viewed as being less than. They get nervous with, no offense, the white coat. They come in and there's this immediate stigma where they know eyes are on them, that they're viewed differently. So there's these big systemic barriers. Insurance is a thing. 2/3 of the time when you give them a referral, they don't show up, not because they don't want to, but because they can't figure it out. Call this number, get an appointment, show up. Where do I go? How do I call? What do I do? It's hard. Third, provider-based barriers. 2 biggest things. I don't want to treat these patients because they're not going to be adherent and they're just going to get reinfected. 2 things that you hear over and over again. A lot of providers not comfortable with the ongoing substance use, with the ongoing drinking or drugging, whatever the case may be. They don't feel comfortable in managing it. Yeah. So first thing is adherence, okay? This is data. There's a ton of literature about this stuff. People who inject drugs, they really, it's like, maybe they wanted to listen.
The lawyer that was listening.
Yeah. Yeah. That guy's like, wait a minute. You're the guy giving Adderall to meth heads.
Is there a secret formula?
Sure.
Sorry about that.
No.
Hello?
Tell them, either read the mayor or leave a message, please.
Wrong number. Bye.
What's his number?
I don't know. Sorry.
I have some revelation.
You could not have called it a more perfect time, though.
Okay. I'm sorry.
I think it's one of yours.
Yeah.
I'm going to hang up on you now. I'm sorry. It's the wrong number. Bye.
I'll tell you what. 100% that individual has Hep C. And he is currently high. But that was perfect, man. Like, I couldn't have teed that up any better. He's in Buffalo right now. He's one of mine. He somehow got the number.
We couldn't have made that up.
No, that was great, man. I'm totally off the reservation now. Where am I with this thing? Adherence rates. Okay, so there's a ton of data that was awesome. That these patients are adherent to therapy. Okay, this is not 100%, but 92% when you compare it to the general population. It's equivalent. So it's an interesting thing. When we took over in Buffalo and started treating patients who were actively using, I asked for 10 patients who had Hep C, HIV, and ongoing drug use, and they wanted to know why I wanted them. And I said, we're going to treat them. I said, you can't because they're going to be non-adherent. So we looked at surrogate markers of compliance, clinic show rate, med refill rate, HIV viral loads, CD4 counts. 10 out of 10 came to the clinic 80% of the time, filled their meds 90% of the time. 10 out of 10 had a filthy tox screen for everything. 10 out of 10 had negative HIV viral loads. So are they medically compliant? Yeah, they take their meds, they show up, but they're not compliant with how you necessarily want them to live. If any of you have been, know about opiate withdrawal, you have to be weirdly compliant to a regimen, otherwise you get sick to the point where you hope you die, right? It's that bad. So in a way, they are adherent to a regimen. And I'll tell you, in the old days when we used to use the toxic meds and CVIC and all this other stuff, the patients who used drugs were 100 times more compliant than regular folk because they're used to being uncomfortable. So compliance, there's a ton of literature about this, and they're just as likely to adhere as the general population. Cure rate, same thing. This is not 100%. It's not close to what the current regimens are, which are around 98, 99%. However, this data came from a time when the SVR rates were with different regimens only about 90%. Okay, so I'll show you some of our data in a little bit. This is some interesting stuff that came out of ASLD this year. This was a big Canadian cohort, almost 6,000 people. They followed them long-term to assess reinfection. PWIDs, people injecting drugs, more likely to be reinfected than non-PWID. Well, that makes sense because the non-PWID didn't really have any risk factors. So almost zero, right? But if you look at the rates, the overall reinfection rate was only 1.28 per 100 person years. Now, historically, it's always been around 2.2 per 100. If patients who were injecting drugs remained on the opiate substitution therapy with no interruption, there were no reinfections. And we've seen a very similar trend in our own clinic. This was another study, another Canadian study. What I thought was interesting about this is only about 200 patients that were actively using and underwent Hep C treatment. What I thought was interesting here is that in the Canadian cohort, their drug users with Hep C looked like our old cohort. They tended to be middle-aged male. They had some cirrhotics in there. I don't understand how they broke down the age group in terms of SVR. You can see if they were 40 to 49, they really screwed it up and they only got cured 71% of the time. Everybody else got cured 95%. So I don't know what happened with the 40-year-olds, why they couldn't figure out how to take their meds. Reinfection, though, was very low, and they attributed it, the people who did reinfect, they attributed to being homeless, younger, and poly drug use. So all of those things make sense. The point is that reinfection is exceedingly low. So recently, U.S. Preventative Task Force, they updated the screening recommendations. They now recommend that we screen every person age 18 to 79, regardless of a risk factor. All pregnant women need to be screened, pregnant women under the age of 18, and all active drug users. There was no statement regarding children born to infected moms, but I would argue that they need to be screened. World Health wants to get rid of Hep C by 2030. It's not going to happen in the U.S. We're like dead last, and I'll show you in part why. Treatment's still restricted in a lot of places in the country. You can't eliminate a thing that you're not allowed to treat. Simple. And why are you not allowed to treat it? It's purely based on stigma and how you got the disease, right? So I've been working in Michigan trying to eliminate their barriers, and we always equate addiction to diabetes, right? So basically, name me in human history another disease state where you had to determine your worth for treatment, right? Couldn't get your Hep C treated, still can't in some places until you're clean and sober for 6 months. What are the disease does that hold true? Don't say transplant because that's a procedure. What are the disease? Any? So I sat with the Michigan Department of Health, and I had three old dudes in front of me. And the first guy, I said, imagine your wife gets her mammogram, and she comes to me, and my first question is, do you smoke? And she says yes. And I say, come back in 6 months when you don't smoke, and I'll treat your breast cancer. What would you do? So we sue you. Exactly. Second guy said, okay, imagine you get a colonoscopy, and I tell you got some adenocarcinoma. But it's only a little bit. Come back when it's stage 3 and I'll treat it. What would you do? He said, I'd sue you. So the third guy said, you still got your prostate? And he said, thank you very much. You made your point. You can leave. But the point is that there's no other disease state where you had to determine your worth to get it, right? So I told him, you can stigmatize based on addiction. That's fine, but you have to stigmatize all the disease states. Level the playing field. So if you come in, I can ask you, you have strep throat, you need a Z-Pack. Did you have a glass of wine last night? No? Oh, you did? Sorry. No Z-Pack for you, right? If we blame you for how you acquired the disease, we wouldn't treat anything. And they hide behind costs, the cost of the meds, cost to the system, things like this. You know it's expensive? Colonoscopies on 80-year-olds, mammograms on 75-year-olds. That's expensive. How many times when they talk about reinfection, I don't even understand why that's in the argument. How many times does a patient come into the ER with CHF? That you go, how many times have you been admitted? Oh, this is the second time? Go home. You don't even think about it. You don't ask, you just do it. How many rounds of cancer treatment do you give patients? Till you fix it or they die, right? So the same should hold true with Hep C, but we're still not quite there yet, and it's based on how you got the disease. Okay, soapbox portion of the talk is over. I wish that guy would call back. You can listen to this. So I told you, we're dead last. We're not doing a good job in the U.S. This is like one of the report cards from National Viral Hepatitis, the progress report. If you look at our rates of acute Hep C, instead of going down, we're actually going up. So we're failing miserably in that regard. These are what the restrictions look like in 2014. Red is bad. Red means you have either sobriety, prescriber type, or fibrosis restrictions, okay? We've made progress, but we're still not quite there yet. I think this hasn't been quite updated because New York now has no restrictions at all. So we're doing better, but they're still in play. So even if we got rid of all the restrictions, this came from Kentucky this year at ASLD, and it's really interesting because eliminating the restrictions, treatment rates don't exactly go through the roof. So there's more at play than just access to medication, right? There's things like infrastructure. Are there prescribers? Can you engage the patients? Can you engage a patient population who for so long has been told you can't be treated? How do you get them back? So a lot of that goes into play. So it's more than just getting rid of those restrictions in place. So how do we improve PWID treatment uptake? Well, the how we do it depends on the where, the what, and the who's doing it. So it's a mix and match approach. We have in 10 states or 12 states right now, there's a version of my clinic from places that I've been and tried to help set up. And what we do is this sort of resource assessment based on the setting, the provider types, and what services they have or they don't. You have to figure out, if you can't draw blood, I'm not going to tell you to do X, Y, and Z thing. We're going to tell you how to get access to the labs. But it's not an algorithm. It's not something that you can make a cookie cutter, because what works here in New York doesn't work upstate, doesn't work in Omaha, for example. There's a million tools in the tool bag. The three big buckets are screening, then linkage. And linkage, not just I gave you a referral, I linked you. It has to be, we have to change the terminology. But it really has to end in the treatment uptake. But how we achieve each of these three tasks is a mix and match approach depending on what they have or might not. So there's conventional referral. We talked about that. 2/3 of the time they don't show up. System's hard to navigate. If you have peer navigators, maybe that helps. You need a multidisciplinary team, that can help. Telemedicine's been utilized in this population. It's okay. It's worked well in rural settings. It's worked well in prison. one of my colleagues has a study going on right now, Andy Talal. He got a PCORI grant to look at Hep C treatment in the addiction settings. What we've seen is outside of a grant, it's not sustainable. It's hard to bill for, reimbursement's terrible, hard to justify to your institution that FTE, that there's value on the dollar for it. So in my shop, we haven't utilized it much.
Actually, we're using it.
Yeah.
To get the methadonians to
Yeah.
get treated, because they won't cross the river.
Exactly. Right. And is that's within your own system, right? Because you guys have like 11 clinics or something.
Yeah.
Right?
we've got like-
And
We are enrolled in the Party study with Andy.
oh, so you're doing it under the guise of the grant.
Yeah.
That's good. Outside of the grant, it's
Yeah,
a
but
little
we can
tough.
write the prescriptions in Union Square, and actually they're 340B eligible. So
They are 340B eligible. Oh, so that's your sustainability piece. That's huge. So as long as all that funnels through that 340B, bam, it's a sustainable program. Yeah, that's good.
And a lot of the telemedicine stuff has shifted over the last year. So like now even patients don't need to be located in an Article 28.
Right, they can be elsewhere. Yeah, that lifted. That's what I thought. As long as the doc is in, yeah, that's right. And then finally, this co-localization, which is, one-stop shopping. You come to one place, you get all your needs met in one place. I'm going to explain our program a little bit. It's kind of a hybrid of all of this stuff. Everybody wants to get into these addiction facilities. They all want to treat everybody's Hep C within them. But what we've seen is that there's a lack of understanding about how each of these places works and what's possible within each place. So in detox, you're better off for screening because you're only there for 3 or 7 days. A rehab, something that's 30 or 90 days, you could screen and initiate treatment. Outpatient Suboxone works real well because they come in pretty frequently, either weekly to monthly, but there's constant contact with patients. Methadone clinics are tricky. Some places are simply juice factories. I'll show you a picture of one in a minute. You show up, you get your dose of methadone, you never see another human being, you spit your methadone back out in the cup, you sell it for fentanyl, and off you go, and you show up the next day. And no counseling, no anything, not much happens. Some programs, like some of yours and where I used to work at Cornell, comprehensive medical, they can draw blood, they have counselors on site, patients see the doctor, see the counselor. So there's a lot of variability. Some of these places can bill, some cannot. They receive a flat fee per head per patient. Those places are hard to incentivize to start doing Hep C treatment. This is a juice factory. This is across the street from a Dunkin' Donuts in Buffalo. This is 7 a.m. I get gas. For some reason, I always get gas on Tuesday, and these guys are lined up. And so some of them were my patient, actually, and they found me at the gas station, and I took them to breakfast in the Dunkin' Donuts, and they introduced me to some of their friends. There's no screening going on here at all, so we now show up at Dunkin' Donuts on Tuesday with our rapid antibody test kits, and we freaked out the whole staff. But now they're used to us, and they tolerate it, so,
As long as you're buying donuts.
that's it. Get your cruller and stick your finger with this thing for me. But this is a juice factory. They just line up and off they go. And you see more drug deals happen on this block. Because if you want to go buy drugs, this is just a PSA, go to the methadone clinic because that's where all the drugs are.
They don't mind you driving a Volvo? They don't mind.
No. Actually, I was putting windshield wiper fluid in it, right? And my guy came up to me and he said, Doc, did you buy that? I said, what? The windshield wiper fluid? And he goes, yeah, did you pay for that? I said, yeah. He goes, no, you don't buy that. He's like, when you need it, he's like, you steal that shit. So I was like, I'm probably all right. I had my kid with me that day. And she was in the back of the car, and she goes, there were like 4 of them, and she calls me Papaya. She's like, Papaya, you have some really interesting friends. Yeah, I sure do. They call me when I'm doing grand rounds, man. They're looking for the mayor. So I'll just wrap this thing up with a little bit on our program. We call our clinic the bodega. It looks like a New York City bodega. It's got a pull-down metal gate in the front of it. We do about 3,700 visits a year. Pretty much everybody's on drugs and has Hep C. And we've seen a shift, like some of this stuff that I've told you about as they get younger. So we've partnered up with like 20 addiction facilities in the area. I can't be in all the places, and sometimes it's tricky to overcome some of these barriers. So we've given each of the places an individualized screening protocol. The social work team then goes out. They know all the staff. We've told the places, if the test is positive, put them in a pile. You don't have to fax, call, don't do anything. Put put them in a pile. My guys collect them, bring them back to home base, make the appointment, hand deliver the stuff back. That eliminates the navigation portion of it, right? Then they stay in constant contact with the patient. All patients have our cell phone numbers, mine included, hence my guy. They have open access, so they stay in contact with them, and they constantly, you have an appointment next week, can you get there? Yeah, I'm good. You have an appointment tomorrow, can you get there? No. Why? My cousin's my ride, got arrested prostituting, I can't get there. We send Uber Health, or we go and get you, or the peer navigator. So then when they get to us, it's a co-localized approach where we manage their Hep C, their HIV, their MAT. So we start two things on day one. You get your script for Suboxone, you get your script for Hep C meds. And as a result, since 2016, we've treated like 3,000 people. This past year, we just looked at a certain cohort. These were like active users, like fentanyl, 3 gram a day fentanyl users, almost 300 of them. 82% completed treatment. There's still a bunch that are on therapy. This has been updated, a bunch of them finished. 45 didn't complete, but a lot of them did end up getting cured anyway, which is interesting. 98.8 SVR rate. You can see the age distribution, they skew younger. So, and these are the baddest of the bad. Heavy active users. Adherence in that group, I don't know why it came out like this, sorry. Very interesting. We actually do have regular people in the clinic, and the regular people's adherence was 73%, and our guys, 84. So there it is. Our crew did better, and it's the exact same model. No difference. No difference at all. Interestingly, in the model, the show rate is 90%. So we see 45 people a day. Over tomorrow and Friday, I have 90 people on the schedule. Most of them show up. Reinfections. Out of the 3,000, we've only had 5. And we have them on MAT, so we follow them long term. Of the 5, they all got retreated. Everybody got cured. Interesting thing here is of all the patients that came in actively using, almost half who were not on MAT initiated it. So that's important, because in the old days, it was like get clean and sober, then get Hep C treatment. This shows you Hep C treatment is a gateway to lead to treatment of the opiate dependency, right? So by the time you start your Mavret or whatever, treatment's over. I have you stable on Suboxone. The Hep C part's already done, off the table. So I've been asked a lot, why does the model work? I presented this once at Johns Hopkins and again at the CDC, and the question kept coming up, what's the secret sauce? And I give the same answer every time it comes up, and why, and the answer is don't be a dick. DBAD. We're putting it on t-shirts. And it's, what I mean by that is we meet these patients where they are. When they come in, happens 10 times a week. I see them, I leave the room, the nurse is checking them out, and they go, when do I see the doctor? I wouldn't believe me either, you know. Hairy tattooed guy, that's the doctor? You know, he looks like an electrician, like an Iowa dairy farmer or something. But part of it is it's stigma free. There's open access to all of us. They come in, we feed them, we live and die with them, you know. So we give each place a protocol. It's individualized. It's not just, you know, here's the guideline, go do it. We go in, we assess what you have and what you don't, and we try to make it work. And then that co-localization, that one-stop shopping is helpful because it's all the things happening at one place, one time, with a stable crew that they know. And all we're only 6 people. It's 6 of us that do this, 2 social workers, 2 nurses, me and a PA. It's a super lean, mobile, you know, unit. But everybody's handpicked, and they all have to have the same mentality. So 35% of our patients are referred by other patients. They walk in 5 o'clock on a Friday when we're about to close the bodega gate. If you come up to the window and say, I have Hep C, I'm buying Suboxone in the street, they know, you don't even ask, you add them to the schedule, we see them and do what needs doing. So that's part of why it works. We started this thing out of our detox where when they get admitted to the 9th floor for detox, everybody gets screened for Hep C. That happens everywhere. What we did though is if the test is positive, it automatically triggers the EMR to send a consult referral. Happens instantly. It also triggers an email to both me and the social workers. So the patient comes in, detox, boom, test positive, reflex testing. We get it same day. We go in and see them in the detox. The whole Hep C workup gets done that day. They come down from the 9th floor to the 1st floor. They get a script for Suboxone. They get the script for their Hep C meds. So we started doing it this year. About 50% of the consults were just for MAT. About half were for MAT and Hep C. Again, this is old. These numbers have changed a lot. But when we first put this up here, there were 55 people that were chronically infected. 24 started treatment. 8 got cured. The rest were still on treatment. This is up to like 110. And the SVR rate right now is it's the same, 98.9%. And we've treated about 70 of them just out of the detox. So this is another example of active users who are not even in recovery yet being able to treat them. So Hep C is at the end of the beginning of the end, or the end of the beginning. I think it's the end of the beginning. We have all the meds we need, no side effects, almost 100% cure rate, no shots, no. But we have to engage this population if we're going to get even close to eradicating it. Right now, new cases are exceeding treated cases, and it's all in the back of where these patients are at. And yeah.
May I ask how often do you do the blood tests in your population? Like,
Which blood tests, you mean?
HCV, RNA, or,
The RNA?
Yeah.
When they're on treatment, or after they've completed and cured?
Well,
So after they're treated and cured, if they tox positive, we check it again because it means they relapsed. On treatment, we've been checking it at week 2, not because you have to, but because the payers still wanted a week 4 RNA. So we do it at week 2 because if you do it at week 4, it takes 2 days to come back. It takes a week for Fidelis to lose it and blame you for it, and then they lapse and they don't get their second refill. That's a big pain. So we do it that way. But we've had patients that get their meds and get one RNA and they get the next one is their SVR check. So this is a flag I had made that I hung up. Come one, come all. It's kind of our motto, our rallying cry. All the patients can see it. It's kind of cool. This is just a piece of one of the walls in the clinic. So when they get cured, we let them graffiti the wall, and they leave a message. They whatever they want. They write their name. There's 3,000 names all around my clinic now. And we had like a dinner triangle, like the cure bell. And this one old lady was so excited when she got cured, she pulled the whole thing right off the wall. And it left these 2 big holes. And they tried to paint my clinic and fix it. And I was like, no, it just goes with the aesthetic. It's fine. So we got a new bell. It's a cowbell. It's a legitimate, like, Guns N' Roses style cowbell. So they get cured. They write their name. They ring that bell. They scare everybody. This is a guy, Brian, who we treated. He had been treated a bunch of times for Hep C. And we did him with new meds. And he was a mentally challenged guy. And this was his panel that he decorated, and he wrote, "Live now and hold your heart for tomorrow." And he rang that bell for like 5 minutes, and we're all crying, everybody's a mess. And we thought it was very profound, so we put his slogan on T-shirts, because when you cure them, you want to give them something. You can't give them a T-shirt that says Hep C free, because then they're out there and everybody's like, whoa, or like, I beat the bug, like, so I give him this. That's it. This is my crew: Ange, Crystal, Karen, Steven. They're the ones that make it work. So thank you all very, very much for bringing me down. I appreciate it.
Thanks, Tony. Questions?
We have a cure party every year.
Yeah, we do the cure party too. It's fun. They like that.
And you don't tell anybody what outside what the cure is.
Yeah, it's funny in the cure party. At least our guys. Yeah, some of them brag, but then they're surprised, like, "Oh wait, you too?" Like, "Oh, Eddie, you have it."
It's a little reunion.
Yeah.
We have in the waiting room a lot too.
Yeah. Well, they violate their HIPAA all the time. At that gas station, another day I'm pumping the gas, and the place is full. And one of my guys came from the methadone clinic. He's like, "Hey," he's like, "Dr. Tony," he's like, "I've been taking my Hep C meds every single day at the same time." I'm like, "All right, I think you just violated your HIPAA to like 55 people, but good for you."
That's really great. During your talk, I know the patient population you say is much younger than what we see here. So you probably are seeing a lot more women of childbearing age.
Yeah.
Are you seeing a lot of pregnant women
Yep.
coming through, and how are you
Yeah.
There's a lot of debate, there's a lot of data that
Yeah.
we're waiting to see come out to hopefully change practice.
Yeah. It's emerging more and more. So I think I went from seeing like almost, 2 pregnant women a year to like 20. And we've tried to kind of follow them and make sure we have them on a database that we know where they are, when they're due to come back, screen the kids. The question's been when to start treatment. And I think it's starting to shift more and more. And I'm curious, Doug, what your opinion is about that 3rd trimester and starting them there. And personally, I think that's I'm all in on that. Tatiana's doing it. She's in clinic, if that's who you were looking for. Yeah, I know you guys had a
We've
few.
treated a few, and
Yeah.
the problem is the new epidemic is largely genotype 3.
Yeah,
So we have, category B for our own,
right.
so we can use that for the months,
Right.
7, 8, 9,
Yeah,
or something. That's not a problem. But there's, 1.
right.
But then we're still waiting on the
Epclusa.
PK study from
Yeah.
Australia and Pittsburgh about the
Yeah.
Epclusa in pregnancy.
Right.
I can't imagine it would be any different.
Yeah, I
It's
agree.
like without data, everybody's so worried about.
Right.
Although our OB person, our vice chair of OB, Rose Perry, is she pioneered AZT therapy and
Right.
in pregnant women in the 90s. So she's fine with with us going ahead. We're just kind of waiting for that data.
Yeah, and once you see that PK side, then I think it's going to be, I think people are going to go off and do it. I mean, that vertical transmission risk is high enough that I think it makes sense. I mean, you're preventing 2 infections, potentially curing and preventing it. Yeah.
Also, they're on
That's-
Medicaid.
They have Medicaid. The second they deliver, the Medicaid's off,
No, I
and
think they get 3 months. I think it's like a 12-month.
still it's short. If
Yeah.
you lose them by the time you've done the PA, you got them then in that moment. Do them,
Yeah, we're working on it. I think it goes to both or high risk OB.
Yeah, that's awesome. Other
Wonderful
questions?
talk. Thanks.
Great, Tony.
All right, thank you all very much.